Hi, everyone. My name is Dr. Jessica Farrell. I'm a clinical pharmacist at the Center for Rheumatology and associate professor in the Department of Pharmacy Practice at Albany College of Pharmacy and Health Sciences. I'm also the co-medical officer at the Stephan Scleroderma Center with Dr. Lee Shapiro. And I'm also on the board of trustees for the Rheumatology Advanced Practice Providers, and I also serve as a member of the Scleroderma Foundation's Medical and Scientific Advisory Board. I am very happy to be here today to talk to you about medications in scleroderma. I've been giving this presentation for a couple of years now, and I've talked a lot about kind of all the different medications, and I've talked a little bit in more detail on some than others. So this year, I'm going to focus a little bit more on some of the newer treatment options that are available and a little bit more depth on the immunosuppressive therapies. So in terms of disclosures, I have no relevant conflicts of interest related to the subject matter of this presentation. I do serve on a variety of advisory boards and as a consultant for different pharmaceutical companies. So as you all are well aware, there is no single drug therapy that's been approved to treat all the aspects of scleroderma. Because it's affecting multiple organs, we have to target therapy towards an individual's disease progression and disease symptoms. So each patient, if you had 10 scleroderma patients in a room together, everyone's treatment plan might look a little bit different. And that's how you work with your rheumatologist and your other providers to really tailor the treatment to target your disease specifically. We're often targeting a couple different aspects of the disease. So we may be targeting inflammation, autoimmunity, the vascular disease, or tissue fibrosis. We do want to make sure that routine screening and early treatment for internal organ manifestations to improve disease outcomes. So it's really important that you're working closely with your rheumatologist and other providers to make sure your treatment plan is on par with your disease progression. From a pharmacologic perspective, we have lots of different medications that we are going to talk about. We're going to talk a little bit about some of the ones on the left here, and then talk more detail about some of the immunosuppressants. And when we're looking at treatment options, like I mentioned, we're going to be focusing on using a medication to treat that aspect of the disease. So we have medications that are vasodilating and Reynads, which open up the blood vessels in the extremities, like the fingertips. We have medications that help the GI tract, so either help the GI tract move a little bit faster, maybe a little bit slower, depending on your disease. Also antacids to help with the reflux. And some patients might actually need some antibacterial agents to help rebalance the bacteria in their gut. We have medications that we use for pain. NSAIDs we have to use sparingly and be careful because of their side effects. We'll talk about a little bit about that. We'll talk about some of the analgesics and issues with corticosteroids. As in regard to immunosuppressants, we have a variety. I have only a couple listed here. I'm going to go into more detail about these medications. And same for pulmonary hypertension or interstitial lung disease. We'll talk a little bit about those. And I'll briefly mention renal crisis and ACE inhibitors. I'm not going to talk in detail about those today, but I'm sure they're covered at some point during the conference. So from a pharmacist perspective and from a patient's perspective, in terms of educating your healthcare providers, and might help bring some perspective to interactions that you have maybe with a pharmacist or your insurance company. FDA approved indications mean that the medication has been studied in a patient population and has been a large study that has shown efficacy and safety, and that the FDA, the Food and Drug Administration, has reviewed all of that data and has said, yep, this medication is effective, the benefits outweigh the risks, it is approved for X disease states. Unfortunately, in scleroderma, we have very, very few medications that are approved for any aspect of scleroderma. So for the most part, we're using many of the therapies off-label. And the reason I mention this is just to really put this into perspective for you, because we may have issues with insurance coverage because the medication's not recognized for your disease state. So oftentimes this requires your provider or the provider staff to help the provider pull together data and studies and information to support the use of a medication in scleroderma. And it might take a little bit longer to get the medication approved. So just wanted to point out those differences. I know that it can be a really frustrating process, but understanding kind of the behind the scenes, I think as a patient can help you navigate the system a little bit easier. So let's talk about Raynaud's, and I have presented this medication table before. This is medications that are used in general for Raynaud's. So basically what all of these therapies are doing is opening up the blood vessels in the periphery, particularly the fingertips, but other places too. So calcium channel blockers like nifedipine and amlodipine are commonly used. The one thing that we do have to worry about or watch out for is that these medications, because they're opening up the blood vessels, they can drop the blood pressure, and they can cause what's called peripheral edema, or like swelling in the lower extremities like the feet or the ankles. So we have to sometimes balance the dose. If someone has already really low blood pressure, we have to be really careful adding this medication. You might need to, when you're standing up, you might get a little lightheaded. So it's important that, especially after you wake up in the morning, you're moving your legs around, you're kind of sitting up slowly, making sure that you're not getting that kind of lightheadedness when you stand up. So that's one of the biggest things to keep in mind with this class of medications. Sometimes we'll add on ARBs that have a little bit of data in Raynaud's, and usually they're just added kind of as an adjunct. But those are drugs like losartan, valsartan, same types of things, but probably tolerate a little bit better than the calcium channel blockers. Don't really use alpha blockers anymore like prazosin, but it might be used in refractory cases, just because it does cause a lot of low blood pressure and kind of lightheadedness. Nitrates, so topical nitroglycerin is something that can be used or compounded into, commercially it's only available as an ointment, but it can be compounded at a compounding pharmacy into a cream, or what we call a POL gel. That can sometimes happen, can be done, and that can help for just topical. So you apply it to the fingertips, to the toes, and it's limited in terms of, using it for more mild disease. The commercially available ointment can be a little tough because it's an ointment, so on your fingers, so you have to maybe put gloves on after you put it on. And in terms of the compounded medication, it's likely not covered under your insurance, so you have to pay out of pocket for that, for a specially made product. And then phosphodiesterase inhibitors, so sildenafil, tadalafil, these medications have really changed the way that we're able to treat Raynaud's. The issue is sometimes coverage and cost, but for the most part, these medications are tolerated pretty well. They can cause some headaches, some, low blood pressure also, but they work really well at keeping Raynaud's under control. And also if a patient has any ulcers, so I'll talk about it on the next page, right there. So these are the medications that are also used if a patient has ulcerations at their digits, and which is basically due to lack of blood flow. So the phosphodiesterase inhibitors are probably the most commonly used for digit ulcers nowadays. They can help. They've been shown to improve healing, and they're a lot easier to administer compared to some of these other medications like the prostacyclins, like Flolan. Those medications have to be administered in the hospital and or in a controlled setting, and it's tough to tolerate. So it's kind of been a challenge to use. So the phosphodiesterase inhibitors are definitely more helpful from that regard. In some patients, I mentioned here, it has visual impairment. We do need to be careful if patients start to have visual impairment. Sometimes these can be described as kind of issues with peripheral vision. Sometimes people can have even see things that are not really there. So those are things that we want to watch out for. So making sure that, you and your rheumatologist start on the same page in terms of physical assessment and vision checks. And then those last medications are really for refractory use. They are also used in pulmonary hypertension, but they have to be obtained from a special pharmacy because they have such severe side effects that they have to be under a really tight control. That's what a REMS program means. There's only one pharmacy that dispenses it. There's lots of medication monitoring that has to be done, more additional than others because of the liver injury. So they're really not used very often at all. I think one of the biggest things with Raynaud's is to making sure that you're avoiding certain medications that can cause constriction. So especially for people that are maybe have a newer diagnosed disease, or Raynaud's maybe is only an issue at certain times. Maybe it's because of some of the medications that have been added, or the use of caffeine or nicotine. So keeping in mind that all of these medications that are listed here, I like to point out pseudoephedrine because it's available over the counter. These medications can cause vasoconstriction, so the blood vessels to tighten up instead of staying dilated. They tighten them up, and those can actually can trigger Raynaud's attacks, or just make them worse or make it harder to treat them. So these are all things that we want to try to avoid. Pain management. So pain management can be really tough in scleroderma because there are lots of concerns to the medications that we have to help with pain. NSAIDs, so drugs like ibuprofen, naproxen, it can cause esophageal concerns, so irritation. They can damage the lining of the stomach. So we have to be really careful using these in patients with scleroderma because most patients, their GI tract is affected. Basically, what these medications are doing is blocking the protein, I guess I'll say, that is making this protective lining in your protective coating on the stomach lining. And by doing that, it just puts your lining at a higher risk for ulceration and damage and irritation. So, we have to be careful and use those sparingly. They can also affect your kidney. So we have to be careful with that. They can cause constriction in the kidney, and we just have to be careful of overuse of those medications. They can also cause blood pressure changes because of the effects on the kidney. So those are things that we have to keep in mind, and making sure that if we're using NSAIDs, we just need to be monitoring those things. Steroids. So steroids are a great class of medications. They work really well to get inflammation down. They're potent and anti-inflammatory medications. So if there's a lot of inflammation occurring, we give steroids, and it really helps calm things down. In scleroderma, we have to be really careful if a patient has RNA polymerase III antibody, because that is a risk factor for scleroderma renal crisis. So this antibody positivity plus adding steroids really puts the patient at much higher risk for renal crisis. So they should be avoided for the most part, or used in extreme caution in that patient population. And then opioid medication. So, everyone is familiar with issues with opioids. We have, an opioid epidemic in the country. The overuse of pain medications. It frustrates me as a healthcare provider because I feel that we we're all about treating pain and making sure people are out of pain. And then we, didn't recognize to manipulate therapies the way they should have been manipulated. So now we've kind of pushed all the way to the other end where we're, stigmatizing patients that need these medications. So if you have legitimate pain and you need opioid therapy, it's okay. We do need to be using them cautiously. And you need to work closely with your provider and making sure that, all the boxes are checked in terms of the legal concerns and things like that. But I do think it's important to recognize that, opioid medications have their place in therapy, particularly in acute pain, and they should not be avoided because of the, concern with overuse of opioids. They just need to be used properly. So in scleroderma patients, we have to be careful with opioids because if you have constipation associated with your disease, these medications can really cause that to just be much worse. They can exaggerate it. It can cause, worse constipation, and that can be a problem because they slow down the GI tract. And then risk of respiratory depression. So because scleroderma often affects the lungs, we have to be careful about the CNS or central nervous system effects or drowsiness, the calming of the respiratory system that happens with opioids, because we don't want to put a patient at risk for respiratory depression. And then, keeping in mind that maybe focusing on what we call a multimodal pain approach, which is a little bit of opioids possibly, and then adding on other non-opioid therapies. And that way we're kind of targeting the pain pathway from multiple angles. So we might add a medication like Cymbalta or duloxetine to a little bit of opioid to help with the pain. And that way we're kind of getting two separate sides of the pain pathway that can be beneficial to patients. So we don't have to use lots of opioids or high doses of opioids to help with the pain. We might add on medications like Lyrica or gabapentin to a little bit of opioid, or combination duloxetine, Cymbalta, and Lyrica. Maybe that's the combination that works. So it's hard for a clinician to say, like, these are the two medications or this one medication is going to work perfect for you, but it's often trial and error to see what works best in terms of pain. From the GI tract perspective, one of the first symptoms of scleroderma is often very, very severe reflux. And we need to recognize that, severe reflux, overproduction of acid, or the lack of the ability of the sphincter at the bottom of the throat to stay closed, allowing acid and food contents to come back up. We need to recognize that we need to get that acid under control to really prevent the damage to the esophagus. And by doing that, we have a couple different medications. So our first line is proton pump inhibitors. These are medications like omeprazole, lansoprazole, esomeprazole, and so on. And these medications are really, really, really effective at turning off these pumps. So you can see in this picture here, you can see that I don't know, my cursor is, there we go. So you can see that this is a parietal cell that pumps out acid, and basically what's happening here is the proton pump is being turned off. So that pump, when you take the medication, these pumps are turned off for the day, for the length of the time the medication works. It doesn't turn off all of the pumps, but it does turn off a good amount of them. Other options we have are H2RAs. So ranitidine, which is actually off the market now. I apologize, I didn't update this slide. Famotidine is my preferred option anyway. So ranitidine had an issue with contaminants in its production, so it's been pulled from the market. I believe that it will be back, so it'll certainly be an option again in the future. But for now, famotidine is our main option. There are others that are available, but this is my preferred one just because the other over-the-counter H2RA does tend to have a lot of drug interactions, so I like to avoid it. Some of the side effects for any of these medications can be decreased absorption of vitamins. So that's one of the main things that we're worried about with the proton pump inhibitor specifically, just because you need acid to absorb things like calcium and magnesium. So if you have to be on these therapies, which we don't want to put you at risk for damage to your esophagus, we have to keep in mind that maybe you need additional vitamins or supplements, or to edit your diet to make sure you're getting more of these when you're on antacids. There have been over the years lots and lots of concerns for long-term use of proton pump inhibitors. They have been in the news and associated with lots of different things. Some of them are reasonable, some of them are not. These medications, for instance, don't cause Alzheimer's disease, but there are some studies that suggest, like I mentioned, decreased calcium absorption, and maybe long-term that could put you at risk for osteoporosis or low bone density. So things like that, that we just need to recognize, talk to your doctor about that and make sure that, the dose that you're on, if you're on the high dose PPI therapy where you're taking one in the morning and one at night, maybe you could do a trial of an H2RA at bedtime instead of double dose PPI. Those are options to play around with. But again, untreated reflux can cause severe inflammation in the esophagus. It can cause damage in the long term that can increase your risk of esophageal cancer. So it's really important that we are treating the reflux and we're balancing the safety of the medications. Other GI medications and GI treatments. So some patients have bacterial overgrowth in their GI tract, meaning that they just have the wrong mix of bacteria. So we all have bacteria in our GI tracts, but some patients have a different mix that's not really helping them. So we need to kind of give them antibiotics to get things back in balance. And we do that cyclically, meaning that maybe for a week on, a week off, or 2 weeks on, and then a week off, and then cycle to a different antibiotic. Those are different approaches that can happen if you're having a lot of GI issues, bloating, irregular bowel movements, things like that. And you can talk to your GI specialist about that. Pro-motility agents, so there are medications that are used that can increase the movement in the GI tract, but we do have to be careful about their long-term side effects. So a couple of medications like metoclopramide and domperidone. So domperidone is not available in the US, so we have to be it does have some safety concerns. So we have to make sure that everyone's on the same page. All of your healthcare providers know about it, particularly your pharmacist, because it's not going to come up in their dispensing system. So if they are filling a medication for you because domperidone is available outside of the US, we have to make sure that they're aware that they can manually check some of the drug interactions. So again, these are very much a team approach. And if you're, keeping in mind that maybe you need to educate some of your healthcare providers, like possibly your pharmacist, a little bit more detail about the medications that they may not be familiar with. Here's a chart or slide that basically just shows, agents to avoid if you have decreased GI movement. So your GI tract goes much slower, you're prone to more constipation. So here's a list of medications that you should avoid that can make your GI tract move slower. And then if you have diarrhea as an aspect of your disease and your GI tract is on kind of a faster movement, these are some of the medications that you'd want to avoid or just use very cautiously, as they can make the movement faster. All right, so we're going to talk more detail about immunosuppressants and biologics. So we have this table here, which has a bunch of the medications that may be used in patients with scleroderma. So you can see that the medication like methotrexate is listed on the left, and then it talks about the different types of uses the medication might have in scleroderma. So these medications in other disease states are called disease-modifying antirheumatic drugs, or DMARDs. So DMARDs have been shown to slow the progression of the disease in other diseases, like, for instance, rheumatoid arthritis. So that's where that term comes from. But we like to borrow from other diseases and use these medications to treat some of the aspects of scleroderma. While all of these medications are effective in different aspects, they also have some safety concerns. So we'll talk a little bit about that. Methotrexate is used in patients that have inflammatory arthritis or maybe myopathy, maybe diffuse cutaneous disease to help with the skin. Methotrexate works on, this is a hallmark drug that we use in rheumatoid arthritis, and it works on rapidly dividing cells. So if you think about that from a side effect profile, you think about cells that turn over fast, or mucous membrane. So in our mouth, patients on scleroderma are more prone to mouth sores. They can get some nausea in the GI tract. They can get hair loss. The liver, we have to be really careful with. So those are all things that we need to monitor. Hydroxychloroquine or Plaquenil may be the most famous rheumatic disease drug now, unfortunately. And it is a very, very, very safe medication. It is sometimes used in scleroderma for inflammatory arthritis. We do need to make sure that it's dosed appropriately. So your rheumatologist will make sure that it's dosed by weight. So it's 5 milligrams per kilogram per day. And that could be a cumulative dose over the week, depending on your weight. We do need to make sure that you have a baseline and then regular eye exams. If you're at risk for eye issues, you might have to go a little bit more frequently earlier on. But we do need to make sure. But the risk of damage to the eye at the doses we use is very, very low, and it's related to long-term use. So after 20 years of use, the risk goes up a little bit, but it's still, a more rare issue. So as long as we're doing those regular vision checks. Mycophenolate mofetil or Cellcept and mycophenolic acid or Myfortic are two other medications that are very commonly used in scleroderma. Mycophenolate mofetil, Cellcept is one of our hallmark therapies. We use it in interstitial lung disease and also for cutaneous disease. I'd say the most concerning, the biggest rate limiting step with Cellcept is the risk of diarrhea in the initial stages of titrating the dose. We do, have to recognize that it can put you at increased risk of infection, elevated liver enzymes. We have to watch that. We do need to watch for, some of the blood cell counts. It shouldn't be used in patients that are of childbearing age or attempting to get pregnant. So that's something we have to make sure that we get rid of before pregnancy, if that's the plan. And because it does need an acidic, so Cellcept specifically needs an acidic environment in the stomach. So it really needs to be separated from the proton pump inhibitor. So for those of you who take both, although you're supposed to take your proton pump inhibitor first thing in the morning, before your breakfast, really, it's okay to take it closer to food. You don't have to wait that 30 minutes. So if people are on mycophenolate mofetil or Cellcept and a proton pump inhibitor like omeprazole, I say to take the mycophenolate mofetil first thing in the morning, wait 90 minutes, and then you can take your proton pump inhibitor. And if that's not possible, working with your pharmacist to kind of come up with a way that can help you make sure that the medication is being absorbed properly. Azathioprine isn't used a ton, but it can be used in diffuse cutaneous and inflammatory myopathy. Cyclophosphamide is used in more severe disease, so interstitial lung disease. It is really working to wipe out the immune system, so it can have some nasty side effects. It can, have fertility issues. It definitely can cause increase your risk for infection. So, unless we limit the use in patients because we have other treatments now. However, in severe lung disease, we may still use it. So let's talk more about the lung disease. So I'm going to talk more about some of the newer treatment options that are used from an immunosuppressive therapy that are used for interstitial lung disease. We have some older immunosuppressants. So I just talked about these medications, and mycophenolate mofetil has been, has multiple studies to support its benefit. It's a pretty safe option. It's been shown to stabilize lung function in patients with scleroderma associated ILD. We also have cyclophosphamide, which I mentioned, which was shown benefit over placebo in the scleroderma lung study SLS1. So the problem, though, I mentioned is the toxicities. So the long-term side effects to using cyclophosphamide, it is an IV pulse therapy. So we have to, it is something that is a little bit less convenient. So for those reasons, we tend to, favor mycophenolate over cyclophosphamide. And then azathioprine has some data in connective tissue disease, interstitial lung disease, or ILD, but less data to support its use in scleroderma-associated ILD. So those terms on the bottom part is FVC and DLCO are markers of lung function. So, in one study, I can't remember if this was a connective tissue disease study or in scleroderma specifically, if there were scleroderma patients were included, but it showed deterioration in the azathioprine group. So we really need to avoid its use because it really wasn't found to be effective. All right, so let's talk about some of the newer therapies. So rituximab. So rituximab has been emerging as a treatment option for quite a few years for patients with scleroderma, and also overlap myopathy, and also overlap Sjogren's syndrome. So there's lots of data to support its use in those conditions. And more recently, there's been data, not randomized, double-blind, placebo-controlled studies in scleroderma-associated ILD. However, there have been multiple open label and observational studies that have shown benefit in ILD. So one of these studies, which is a 6-month trial with rituximab versus IV cyclophosphamide in 60 patients with scleroderma-associated ILD, and that FVC, the forced vital capacity, improved in the rituximab group and slightly declined in the cyclophosphamide group. So this wasn't the perfect trial, but it does give us a little bit of hope that there is another treatment option to help stabilize the lung function. So mostly the treatments that we're looking at in scleroderma-associated ILD is really, it's hard to improve lung function, but really we're just trying to prevent decline and really stabilize lung function. So keeping that in mind. There are a couple ongoing trials that are looking at ILDs in general. So in connective tissue ILDs, so patients with like rheumatoid arthritis and ILD, but it does include some scleroderma ILD. There is one, so that what's in parentheses there. So if you wanted to go to clinicaltrials.gov and look at that study design, or even see if they're still enrolling, if you could be a candidate for joining the study, you go to clinicaltrials.gov and you can put in those numbers and you can read more about those ongoing studies. But basically it's against cyclophosphamide and then Rituxan in combination versus MMF is mycophenolate mofetil or Cellcept compared to Cellcept alone. So that's a really exciting study set. From observation and practice, we in other ILDs, we do have patients on that combination. So tocilizumab. So this is really exciting because tocilizumab is now approved for scleroderma-associated ILD. So Dr. Khanna and the FOCUS investigators, so lots of the scleroderma specialists that were involved in studying this medication. So tocilizumab or Actemra is used in rheumatoid arthritis, and it has been used for a while. It's also used in giant cell arteritis, which is another condition, and now it has that approval in scleroderma ILD. So very exciting. What I have here is just a little bit about the randomized placebo-controlled phase 3 trial. So it was 200 patients with diffuse cutaneous scleroderma. They were treated for 60 months or less, and they had to have a modified spread and skin score of 10 to 35 at the screening, and they were randomly assigned to tocilizumab or placebo. The primary endpoint was the difference of the change in the baseline of the week 48 in the modified Rodnan skin score. So skin scores were looked at a primary endpoint. The secondary endpoints were related to lung function. So they assessed the percentage of forced vital capacity percent predicted at week 48. And if you look over at this slide here, you can see that the tocilizumab, which is in the red, and then the placebo group that is in the blue, you can see that the statistical significance of preventing decline in lung function at 48 weeks. So very exciting. So essentially, tocilizumab was able to preserve lung function during this time. So this slide just talks a little bit about, kind of gives you a snapshot of all of these medications. That also includes some of the safety concerns. So while it's really exciting that these medications have been shown to be beneficial in scleroderma and other diseases, we do have to be careful about some of the side effects. So with rituximab, it is one of our biggest guns in rheumatology. It is a very immunosuppressive therapy, so it's really wiping out the B cells, which are a big component of the immune system. So it does put you at risk for infection, so we have to be careful about that. It does have this very, 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 very rare risk of a neurologic condition called PML. So it's something that you'll talk to your provider about before you start treatment. It is an infusion, and it's a very long infusion. And we do have to watch out for infusion-related reactions. So during that 6-hour infusion, it might be a little less, but roughly 6 hours, you do have to get medications beforehand to prevent those infusion reactions. Some people get chest tightness, a little irritation in the throat. They might get blood pressure changes. So you'll be monitored by the nurses while you're getting that infusion. Tocilizumab is given as a sub-Q injection, which I believe is how it's approved, but it's also available in the IV form. So approved for scleroderma ILD. It does suppress the immune system also, but to a lesser degree than rituximab. So you do want to still be cautious in terms of infection, risk of injection site reaction or infusion reactions, depending on how you're receiving the medication. It does increase your risk for liver enzyme elevations, and people that are high risk for GI perforation. So if patients particularly that have a history of diverticulitis, we have to be careful. So that's something that we're looking at. The good thing is most scleroderma patients are followed really closely by a gastrointestinal doctor, so that's a good thing. And then abatacept I just threw in here too, because there is some use of abatacept as in terms of it for patients that have inflammatory arthritis associated with their disease. It is a biologic, but it's a little bit more mild in terms of its effects on the immune system. You do have to, we still need to screen for tuberculosis, watch for infections for all of these medications though. The last medication I'll mention is our other medication that is approved in scleroderma ILD is nintedanib. And this is not really new news anymore, but this is another medication that is approved specifically for scleroderma patients. It really is focusing on the lung function. So it's an antifibrotic and it's working to, preserve lung function. It did slow the decline of lung function over 1 year versus placebo in clinical trials. It can be used in combination with CellCept, but it might be kind of its place in therapy. I think it's still finding its place in therapy as maybe an add-on to CellCept. And one of the rate limiting steps is the GI tolerability. So diarrhea was significant. That's pretty much the main one. So mostly just GI effects. It doesn't affect the immune system, so there isn't that risk of infection. Just those GI side effects are the limiting ones. Drug interactions. So I'll just wrap this up and then I have time for questions, but it's important to have a good medication history. So if you are taking over the counters, if you are on infusion medications that don't show up on your pharmacist record, it's important that they know about that. And I've said this many times at many other conferences, is that if you don't have a good relationship with your pharmacist or you don't like the staff at the pharmacy, find another pharmacy. There are, yes, there are certain chains, pharmacies on the corner everywhere. However, you have the right to go to whatever pharmacy you find the best service. So if there's a smaller independent pharmacy or a slower grocery store pharmacy, those might be better options for you so that your pharmacist can spend more time with you. And don't be afraid to find one that will. Making sure that you're educating them just as much as they might be able to educate you on medications. It is it is something that you might need to educate them on your disease state. Sometimes drug interactions are dose dependent. So methotrexate and NSAIDs, so ibuprofen, that's not really a relevant drug interaction, but it does flag. So it's because the dose that we're using is so low in a rheumatic disease, it's really not relevant. And then scheduling, I already talked about this in terms of spacing medications. So omeprazole and Cellcept, levothyroxine. So sometimes you have to play around with your schedule to take the medications and kind of come up with a plan of how to best take them that fits in with your life and making sure that you're absorbing the medications properly. I already talked a little bit about this, but like I said, develop a relationship with your pharmacist. If they're not familiar with Scleroderma, I encourage you to bring them the Scleroderma Foundation pamphlets, help find a way to educate them and find a pharmacist who's willing to be educated on your disease. The computer can tell you only so much. So, if a pharmacist is more educated about your disease state and understands, they might be able to theorize or predict potentially side effects that you might be prone to, or absorption issues or administration issues. So it's important to help educate them so that they can best serve you. Other things, dosage forms. So I think one of the biggest places a pharmacist has a role is helping with different dosage forms or helping identify ways that you can take your medication easier. So some patients have trouble with swallowing tablets, so using things like Pill Glide, that spray, or using like Biotine to help you swallow your capsules, or if the pharmacist can find a different dosage form. So maybe they're able to find a liquid form of the medication for you, or maybe the different dose has a smaller tablet or capsule size, so that's easier for you to swallow. So pharmacists can certainly help with things like that. All right, well, that is all I've got. I wanted to make sure I left a good amount of time for questions. So I am happy to answer any questions for you guys.